Really very warm welcome to everyone this evening. It's great to have you all joining us. My name is Annie. I'm a support services officer here at Ovacome, and I just wanted to take this opportunity to remind everybody that the Ovacome support team are here to provide information and support to anyone affected by ovarian cancer, be that those who are concerned about their risk, people with a diagnosis, as well as their friends and family members. You can get in touch with us on our support line, send us an email, send us a message via the instant chat function on our website. You can contact us on our online forum or via social media, and we can also schedule one-to-one chat via Zoom or Skype, blended them there, if that works better for you, if you prefer that. And the details of all of our support services are available on our website. We're here Monday to Friday, 10 a.m. to 5 p.m. to talk through any questions or just have a friendly chat about anything that's on your mind. We're always very happy to hear from you, so please don't hesitate to get in touch if there's anything we might be able to help with. We'll pop all the details in the chat of how to get in touch if anyone would like to follow up with anything afterwards. But this evening, I am delighted to welcome Laura and Tracie, who are the lead nurses for the Lynch Syndrome National Transformation Project. Laura and Tracie are here to give us an overview of Lynch Syndrome, how it's linked to ovarian cancer, how risk is managed, and as well as ongoing research. So thank you, Laura and Tracie, for being here with us this evening. I will hand over to you now.
Thanks so much, Annie. So I'm going to kick off. I'm Tracie, and I'm a gynae cancer nurse specialist by background of some 25 years, and I'm now the lead nurse organising genetics in the Southwest. There are 7 of us around the country, and I've got the absolute privilege of working with the lovely Laura, who's going to kick off. She drives the slides better than me, so I'm going to boss her with the slides. It's actually not bossing her. There's no point in her trying to boss me. I'm rubbish at it. But we've been working together for about 1.5 years now on the National Lynch Syndrome Transformation Project. Laura will tell you a bit more about that later. So I'm going to start the semi-bossing, but handing over to my tech expert, Laura, to take away the next few slides. Off you go, Laura.
Thank you, Tracie, and thank you, Annie and Nina. Hello, everyone. So as you can see from our presentation today, we're going to talk about the Lynch syndrome and ovarian cancer. So a little bit of background. Obviously, we cannot talk about cancer without talking about genes and DNA. So this is a very quick reminder that inside of every cell, we have our chromosomes, and our chromosomes, you have the DNA and all the genes that they work like a supercomputer. And all these genes, what they do, they give instructions to our body about what they need to do, what job they need to perform. And cancer is a genomic disease and occurs when there is an accumulation of genetic alterations within the cell. And sometimes when these genetic alterations interfere with when the cell copy themselves, as you can see from here. I don't know if you can see my pointer. Can anyone see my pointer when I'm using it? Okay, so as you can see, this is when you are born, you have a normal DNA, and generally after gestation and infancy, you know, due to things like, for example, smoking. Well, you wouldn't be smoking when you're a child, but sunlight, any other chemical, and any other environmental factors might make your cell to accumulate these genetic alterations. Now, when they are accumulated, when they copy themselves, these alterations will be copied. And over time, these genetic alterations might interfere when cells copy themselves, and sometimes it can lead to these cells to copy themselves and not being able to stop, to get out of control. And that's when a cell, like for example here, they become cancerous. They're unable to stop and they can accumulate, and that's when cancer occurs. And that's what generally people develop cancer at a later stage in life. Now, there are also inherited conditions in which people are born with a genetic alteration that predispose them to cancer. What does it mean? That you are more likely to accumulate these genetic alterations, to do a genetic alteration in one of your genes. And I will talk a little bit more about that later. But I just wanted to remind you that cancer is a genomic condition that occurs generally out of the blue and later on in life, but sometimes we do have a predisposition to it. Tracie, back to you.
Okay, I hope you can't hear the dog too much in the background. I can't mute it. I'm really sorry. So, over the sound of the dog in the background, hereditary ovarian cancer, and when we're talking about genetics, many of you will have heard about BRCA1 and BRCA2, and I know the fabulous people at Ovacome do an awful lot of information and give an awful lot of support and help around BRCA1 and 2. So thanks for that, Team Ovacome. You'll find that on their web pages. One of the other genes, though, or hereditary gene predispositions, is called Lynch syndrome. So that's what we're talking about today. And if you look on the right-hand side here, you'll see names. They're numbers, aren't they? EpCAM, MLH1, MSH2, MSH6. Okay, so those are the genes that are linked to Lynch syndrome when we're talking about ovarian cancer. BRCA1 and BRCA2 genes. The other genes are there. And in the middle, there are some more genes that are also linked to hereditary ovarian cancer. Now, a little bit later on, we'll take questions from you. And one of the things that you'll find, and I'm sure you've heard a lot about in the news, is testing on the NHS. And that's become a lot better on the NHS when we are testing for many cancer hereditary predisposition syndromes. So that's like BRCA or Lynch. And it's true. We have a huge test directory now, it's called, where doctors and nurses, when they're diagnosing patients, can actually look to doing that testing rather than having to send clinical genetics. But we can talk more about that later. This is just to give you an overview, really. So the next slide, please, Laura. So cancer risk. What do we mean by cancer risk? I've already used the term hereditary risk predisposition. So in simple terms, that means we have a lifetime risk, all of us, of getting a cancer, different sorts of cancer. And as you can see here along the bottom, 5% lifetime risk of colorectal cancer, 2.8% of endometrial cancer, that's also known as womb cancer. Ovarian cancer that we're talking about today, 1.2%, that's in the general population. And then even smaller, as you can see, less than 1% of stomach cancer. That's lifetime risk. That's for your average person. Of course, no man, and especially women, are average, but that's your average when we're talking about statistics there. If somebody has Lynch syndrome, look at the difference of their lifetime cancer risk. It jumps massively from 5% up to 80% in colorectal cancer. It jumps from 2.8 to 60% in womb cancer. And ovarian cancer that we're looking at today, that's an enormous jump, 24%, which is why we're really, really pleased you lovely folks at Ovacome have asked us to talk about this today, because I, slight chip on my gynae CNS shoulder here, often think that ovarian cancer is missed out too much when we're talking about Lynch. So good for Ovacome for bringing this to the fore. So you'll see in summary, the main cancers are colorectal and endometrial, also known as womb. But ovarian is top of the less frequent cancers, and an increase of 24% is something we don't think we should not be looking at. So that's why we're here today. Over to you again now, Laura.
Okay, and so there are other cancers, as you can see, like urinary tract, gastric, small intestine, skin, central nervous system, etc. But these other cancer, in comparison to the general population, the increased risk is about 5% if you think about it. So it's not huge. So the main concern are colorectal and endometrial, and obviously ovarian cancer, just because the lifetime risk for the general population is only 1.2. That is a big jump. I totally agree with you, Tracie. So there are 5 genes that have been associated with Lynch syndrome. So you can see the names here. They got all funny names. There are too many genes out there. That's why people run out of imagination. But just to say, the mismatch repair genes are MLH1, MSH2, MSH6, and PMS2. And there is a fit gene called EpCAM. Now, if you have a deletion in the EpCAM, the way it works is inactivate the MSH2 gene. So if you are here and you have an EpCAM deletion and you have been diagnosed with Lynch syndrome, your cancer risk will be the same as FSH2 gene. And how does the mismatch repair genes work? So you remember when I was saying that in the general population, over time, you might be accumulating these genetic alterations, and maybe later on in life, you might develop cancer. In fact, the general population, I think the current statistics is 1 in 2 people will develop cancer. Now, for Lynch syndrome, this is a little bit more. And why? It's because the way the mismatch repair genes work. So if there is a genetic alteration that affects one of those genes, then that accumulation of genetic alterations happens at a faster rate. And that's what you have that increased risk. So rather than developing cancer when someone is 80, they might develop it when it's 50 or 60 or even younger. So the way that they work, so you got a cell with the DNA inside, as I mentioned before, then it copies itself with all the genetic alterations that are in there, or maybe a normal cell. And the mismatch repair gene job is actually to correct any mistake that happened during cell division, so the DNA is exactly the same as before. Obviously, if the DNA, if the mismatch repair genes do not work properly, obviously they are not going to correct all those mistakes. So that's why cancer is more likely to occur. Now, something that I would like to highlight here is that not everyone with Lynch syndrome will develop cancer. Now, having this predisposition will make it more likely, but it doesn't mean that. And there is quite a lot of things that we can do about it to reduce that risk, to keep that balance, to keep you safe. I got a little video in here that I'm going to play it that basically explains again how the mismatch repair genes work. So I'm going to play it now. I hope that helps you to understand it. Let me stop it there. So I hope that helps you visualize how they work. Now, what is really important that you are aware of is you have been diagnosed with Lynch syndrome, then your first degree relatives, that's your parents, your siblings, and your children will have a 50% chance of having the same condition. So it's really important that we identify people that may have Lynch syndrome. So we identify people at risk, and then we can put a cancer prevention program in place to make sure that you are kept safe. Now, going back to ovarian cancer, we would like to compare a little bit what are the different risks depending on your genetic alteration. So as you can see, the general population, as we already mentioned, is about 2%. Now, if you have a genetic alteration in the MLH1 gene, your risk will go up to 11%, but when you reach the age of 75. So also the cancer risk is age dependent. So you're not gonna have an 11% risk of ovarian cancer when you are 25. You will have the 11% risk when you are 75. And I'm gonna show you a little bit the prospective Lynch syndrome database in just a second, but I would like to warn you about that. MSH2 and EpCAM, as you remember, the word EpCAM inactivate the MSH2 gene. That's how it works. So it goes from 2% to 17% at the age of 75. And I will explain that in a little bit more of detail. MSH6 goes to 11. And something really important to highlight, if you have been diagnosed with Lynch syndrome and you have a genetic alteration in the PMS2 gene, your risk to ovarian cancer is the same, very similar to the general population. So that's why if you have been diagnosed and they are referring to do some prophylactic surgery that we're going to talk about in just a little bit, it is likely that they will not need to remove your ovaries. So now this is the prospective Lynch syndrome database. You can see the link in here. So if you would like, if you have a diagnosis of Lynch syndrome and you would like to find your cancer risk, you can use this website that is curated, you know, is updated regularly, and there is people looking after it. So your likelihood to develop cancer will depend on 3 factors. One is going to be your age. So the older you are, your risk goes up. The second factor is going to be gender. Obviously, there are different risks depending on whether you are male and female, and the gene that is implicated. As I mentioned before, if you have a genetic alteration in the PMS2 gene, your likelihood to develop ovarian cancer is similar to that of the general population, so something to think about. I strongly recommend that if you would like to have a look at this database, that's absolutely fine. I recommend that you do it with a healthcare professional, because sometimes looking at your cancer risk can be quite challenging because you are looking at your own personal risk, and sometimes it might be difficult to understand. You might get quite scared, so it's actually quite nice to look at it with one of your consultants or with one of your nurses. But if you are going to do it, just to remind you, there is an organ tab, so you can type in here your organ that you would like to look at and what is your rate. There is a gene tab, type in, choose your genetic alteration. Also moving your age, because you will see that if you have never developed cancer, let's say that you are 70, and you are actually looking at your ovarian cancer, your risk it will be less than if you have developed cancer before. So also having a previous history of cancer, that it being colorectal, endometrial, or any other cancer, that also changes the cancer risk estimation. And obviously your gender tab. Now, there is quite a lot of things that you can do to manage your risk. So as Tracie mentioned before, so the main concern for Lynch syndrome are colorectal and endometrial cancer or bone cancer. So for colorectal cancer, we recommend that people have 2 yearly colonoscopies with polypectomy. So colonoscopies are every 2 years from the age of 25 for MLH1, MSS2, and the EpCAM gene, and from the age of 35 for MSS6 and PMS2. That is because the different cancer risks in between the different genetic alteration. Now, things that you can do quite safely, and they are absolutely wonderful, is like, for example, taking aspirin. There is a link in here that I'm quite happy to put in the chat, so maybe Nina and Annie will be able to circulate to anybody that attend the workshop. Now, taking aspirin every day for a minimum period of 2 years can reduce your colorectal cancer risk, and we believe other cancer rate by up to 50%. Now, that is really amazing. Very simple tablet, really good outcome. So if you have a diagnosis of Lynch syndrome and you don't have gastrointestinal problems and you don't have any contraindication, please take it on or have a look at the NICE decision aid. Now, getting tested for H. pylori, just one off, this can reduce your risk of gastric cancer by up to 50%. Then we also make some lifestyle recommendation, the usual, do exercise, do not smoke, use healthy food, do not eat a high quantity of red meat. However, don't take it away. Reduce your alcohol intake, but obviously I do understand that people might want to drink every now and again, especially at Christmas. I wouldn't discourage that. And other lifetime recommendations. So speak to your nurse and your doctors. Now, another research has shown that a resistant starch diet is also really good and can reduce your risk, especially of gastric cancer. Now, what are resistant starch? It's like, for example, green bananas, pulses, etc., including a good amount of this, but without going bananas, just a balanced amount of resistant starch can reduce your cancer rate. So we will definitely recommend that you follow that. Now, if you have a previous diagnosis of colorectal cancer, or you are here because you have been diagnosed with colorectal cancer, there is adaptive surgery and personalized oncotherapy with immunotherapy. But Tracie will tell you all about immunotherapy because she knows it all in ovarian cancer. So I wouldn't be the right person to tell you about that. And after that, there is prophylactic surgery. Tracie is going to tell you about that and PGD, so I'm not going to mention that. But for bowel screenings, for anyone that is in here with a diagnosis of Lynch syndrome, and just to let you know that you should have been called by now by the National Bowel Screening Program. Now they are taking over the colonoscopic surveillance for people with a Lynch syndrome diagnosis. This is absolutely fantastic because there was quite a lot of variability in, some people was having colonoscopies every 3 years or brain board, and people wasn't aware. Now, this move is going to ensure that everybody have colonoscopies in a timely manner every 2 years, and they are high quality. This is really important. This is high quality. Now, I understand that some people might have some concern about this because they have a wonderful team looking after them. That's actually fine. So if you have been contacted by the National Bowel Cancer Screening Program and you would like to stay with your team, just let the people from the National Bowel Cancer Screening Program know that you would like to remain with your team and that you are going to be responsible for making sure that you have colonoscopies every 2 years, please. You can also ask to be moved to another site. So in the National Bowel Cancer Screening Program is, for example, let's say at St. Mark's, and you would like to move to UCLH, that's actually fine. Just let the people that contact you know, and you can move in between sites. So it is your choice. This is really important. And if you haven't been contacted, what you can do is contact the clinical genetics department or the person who provided that diagnosis for you and let them know, because everybody should be contacted. Tracie, back to you.
Thanks, Lara. So my dog's muted in the house now, but the one's barking outside. So fingers crossed we can get through without Dastardly and Muttley too much in the background. Okay, so surveillance. Now, this is the tricky thing for the gynecological side of things with Lynch syndrome, because as Lara was saying, regular colonoscopies, as she was describing, are fit for purpose. They're efficacious, and that's why there's a program. For the gynecological side of things, that's both womb and ovaries. It's not such an easy story. When we're looking at surveillance of the womb, so the majority of womb cancers start in the womb lining. The only way to look at that lining is literally to have a hysteroscopy. So that's our picture on the left-hand side as we're looking at the screen. So that's where and it can be done as an awake procedure. It's uncomfortable and painful, say some women, and both women are right. One size does not fit all in the pain scale of things. So having a hysteroscopy on a regular basis is not really fit for purpose, and there's been a lot of work done on this. It's not the same as having our regular smears, and I know where this is Ovacome that are looking after us, but all of the gynae charities work really closely together, and Ovacome always say, go and get your smears done. So it's not the same as having a smear done. The other way of, so it's a tricky one looking at the womb. It's equally tricky, as your team Ovacome will tell you, surveillance for ovarian cancer. Whether you have Lynch syndrome, whether you are BRCA1 or 2 positive, or whether or not you are in the general population with a 2% risk. Is there a screening program out there at the moment that is fit for purpose, like the smear program? Sadly not. There was a huge trial called UK-CTOX, and you can find some information about that on the Ovacome website, which basically looked at doing regular transvaginal scans. So that's the scan that you can see the animation of on the right-hand side. So that's where the scan that's often done in pregnancy. So the trial looked at, well, could we just scan women regularly? Could we check their blood for the CA125? That's the protein that there's also information about on the Ovacome website that is raised for a number of women when they have ovarian cancer, but not for everyone. So this trial looked at, well, look, if we do these bloods on a regular basis for women, and if we do these scans, surely we can work out if there's going to be an early ovary cancer. And sadly, no, after 10 years in the trial, the answer is still no. There are a select group of women that we're looking at now who do carry the BRCA gene. So for those women, there may be some utility there. So what am I saying in a nutshell? It's not the same in Lynch syndrome as it is for the colorectal surveillance. We really are going very heavily on being aware of the signs and symptoms of ovarian and or womb cancer. That's where talking to the lovely people at Ovacome is really, really helpful. If you're unsure whether or not you have signs or symptoms, we'll have a look in a minute. Please do contact the Ovacome team. They are fabulous and they will support you through this. So next slide, please, Laura. Okay, and there you go. Signs and symptoms of ovarian cancer. Now, this is a very quick overview, and I'm not going to go into any great depth because actually you've got Team Ovacome there 24/7. That website's awake, and their support and their buddies. Please do use them. They're a fantastic team and they know their stuff. So we're staying with Lynch. So we'll go on to the next slide, please, Laura. We're staying with Lynch, and here we are. I've got a slide on HRT and menopause. What's that about then? Well, that's about the risk-reducing surgery side of things. So Laura mentioned, you know, what can we do? So hang on a minute. You've just told me I've got Lynch syndrome. You're telling me the surveillance isn't great. You're telling me to keep an eye on signs and symptoms. Absolutely. So why do you want to talk to me about HRT? Well, because we could consider risk-reducing surgery. So just as with the Angelina Jolie gene, as it's often called, the BRCA1 and 2 genes, where women opt to have risk-reducing surgery, that's removing the organs at risk. In this case, with Lynch syndrome, it's the ovaries and the womb. So if a woman chooses, after thoroughly being counselled and supported, to have her organs at risk, ovaries, plus or minus the womb removed, then actually, if it's before the age of 51, 52, which is the age of natural menopause. What do I mean by natural menopause? When a woman starts to lose her hormones, they go down. That's natural menopause, okay? So if we're removing the ovaries before that, then we really do need to consider looking at hormone replacement therapy. Our hormones are, as well as being some things that stop, so the estrogen, you'll hear about hot flushes. Everybody hears about that. They're not hot flushes. They're an absolute, you're all hot today. It's 27 degrees out there. It's that and double it. It's a real whammy. And it really can affect some women's quality of life. But our hormones, estrogen and progesterone, are also, they protect the colon, would you believe? How funny, we're talking about Lynch syndrome, so we need to think about that. They protect our cardiac health, they're good for bone health, they're good for our cognitive health. Women often talk about, they talk about brain fog. Now, for those of you that the Ovacome listeners who think about brain fog as well, you may think about chemo brain fog, and boy, is that a double whammy. So it's really, really important that we look at HRT and hormone replacement therapy. So do talk to your doctors about that. If you're unsure, talk to your lovely Ovacome team. If they're unsure, they'll get hold of us. We work as a team, a tag team, to look after you. So next slide, please, Laura. Well, because I'm the gynae girl, I always get this one too, fertility. This is seriously important because there's a couple of things here. Let's say we have that risk-reducing surgery, or a woman considers the risk-reducing surgery, then that means if we're going to remove her ovaries, we're going to remove where her eggs are stored. So if she wants to think about having children later on, now if we've removed her womb as well, she's not going to carry her own pregnancy, but she may want to look at surrogacy. So we need to think about having her eggs stored. We also need to think about, another reason for thinking about having eggs stored is we can do a thing called PGD, pre-implantation diagnosis. So what that means is, and this counts for BRCA as well, for those of you who are listening that are thinking about genetic, it covers all genetics in this situation. If we take an egg and a sperm from the partner, or I was going to say random sperm, but that sounds derogatory. You know, it may be a donation sperm. That's what I mean by that. And we can then create those embryos. I'm not stepto, I'm not the clever person, but they can be created within the fertility clinic. The PGD bit is where those embryos are looked at to see which ones carry Lynch or BRCA, for example, and only those that don't carry that gene alteration are implanted back. In other words, so that the parents don't have the concern of carrying on the Lynch or BRCA. Okay, so that's called PGD. Once again, if you want to know more, go to your lovely Ovacome team. If they want to ask us, they'll come to us. We work as a tag team looking after you. So I think I'm handing back to you now, Laura.
Yeah, so this is some facts about Lynch syndrome. Some people might not have heard about Lynch syndrome before, but just to let you know that everybody knows about BRCA, but actually Lynch syndrome is the most common cancer predisposition syndrome that is out there. So it's more common than BRCA. It's not that is less common, it's just very underdiagnosed. And we don't have people like Angelina Jolie that Tracie was talking about before that actually raise awareness, and that's why people knows about it. Only about 5% of people living with Lynch syndrome know that they have Lynch syndrome. So that is about 95% of people that have Lynch syndrome are unaware of it, and they're not taking advantage of the risk reducing program that is available for them. So that is why it's so important to know about it. And for every person that has a Lynch syndrome diagnosis, we discover another in between 3 to 4 people within the same family that also have Lynch syndrome, and they have never developed cancer, and we can offer this cancer prevention program for them. A little bit of an update on the current guidelines. So you might be aware, if you have a diagnosis of Lynch syndrome, that anyone with a diagnosis of colorectal or endometrial cancer are now being tested for Lynch syndrome within their cancer. Now, this is not happening yet in ovarian cancer, but this is going to come, and Tracie is going to talk about it. So I'm not going to talk about it anymore. But thanks to these guidelines, now there is a national Lynch syndrome project, and this is what we wanted to tell you about. So this Lynch syndrome project started in January 2021, and we have collaboration with the 7 Genomic Medicine Service Alliance. You remember what Tracie mentioned, this is the lead nurse for one of them. She's the lead nurse for this one in orange, the Southwest GMSA, but she's also the national lead nurse for the Lynch syndrome project, just to highlight as well. And we are collaborating not just with the Genomic Medicine Service Alliance, but also with the 21 Cancer Alliance in the country. And we are working together to improve services for Lynch syndrome. This is really important because not many people knew about Lynch syndrome before, and I can assure you, if you go to your GP or you go to your oncologist, they know more about Lynch syndrome now, so you are more likely to get better care than what people used to get in the past. So this is basically highlighting all the teams that are working together to actually improve services in Lynch syndrome and to ensure that everybody receives the same care. A lot of really exciting work going on. And obviously there is a national Lynch syndrome nursing team, and I'm gonna hand over to Tracie.
Thanks, Laura. So we've got England covered, as you can see here. So if you find that you are not getting any Lynch care, i.e. information, or you're unsure about anything, and your nurse specialist, if you're being treated at the moment, doesn't know where to turn, you've now got the names of the people, the nurses in your region, and you can give that to your nurse specialist and tie them together so that we can help them support you. Okay. You know, Annie, Nina, please do share these. These are out in the public domain. These are nurses paid by our taxpayers' money, and quite often our nurses, our cancer nurse specialists, don't know who the lead Lynch nurses are, and because it's still fairly new, 1.5 years in the NHS seems like a lifetime to us because we've been working away at it. It's very easy. It's a great big organisation. So please do feel, as patients or family of patients, please do feel empowered. We welcome you putting your nurse in contact with our nurses. That's what it's all about. It's teamwork again. Okay. This is just England here. That doesn't mean we are ignoring the devolved nations, Lara and I. The project is starting in England. So that's where it's starting, it's focusing. But Lara and I believe in equality. Fortunately, we haven't hopped across to Spain, actually, and that's not quite true. We're doing some European work too, but that's not the place to tell you about that now. But we are doing 3 workshops towards the end of this year and into next year in the devolved nations as well. So England, Scotland, Ireland, Wales will all be covered to a certain degree, but this is where the main project is. So Lara and I will be getting out to the devolved nations, so we will make sure the message gets out there. Super, super important. Next slide, please, Lara. Okay, now this is a rather busy slide, but the reason that we wanted to show you this is that actually you should be getting, because of the work that we're doing, upskilling the workforce, you'll see in the middle here, you should be getting more information around Lynch from your NHS teams if you're in England. If you're not, then do put your nurses or one of your clinicians in touch with the Lynch nurses, please do. Or if you don't feel like doing that, you've got enough on your plate trying to deal with the diagnosis and support and treatment, then ask Annie or Nina to ping them our way. We'll do the work, whatever fits for you, we'll support you with that one. But we wanted you to see this because you should be getting more information around the country. And we are passionate to work with Ovacome to make sure that that information is reaching everywhere. So please use us again. I keep saying tag team, but team is the whole thing. If we all work together, we can make it a lot better for everybody getting information. And actually, sometimes it's the things around surveillance, around the HRT, around 1 aspirin or 2, can I take them? All of those kind of things. We're there. That's where we do have the expertise, and we're really, 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 really keen to help. There is a lot of research going on out there now. Lara mentioned NICE guidelines. So one of the doctors that we work with, his name is Neil Ryan. He is a gynae cancer surgeon. He's now in Scotland, actually. He used to work in the Bristol area. He's trying to get Lynch and Lynch testing through NICE at the moment. NICE takes an awful long time to get anything through, but he's trying on the behalf of women with ovarian cancer. He's absolutely passionate about it, and he won't stop. He's brilliant. He's also running a lot of research around Lynch and ovarian cancer. So although I say, and I still do, I'm still banging the drum about ovarian cancer, still being the sort of poor cousin when it comes to Lynch, there is work and it is rising, as is the work in drug therapy, so immunotherapy. We didn't put a slide on immunotherapy for a very good reason. That's because we are in the research phase of the majority for immunotherapy for ovarian cancer. In some of the very rare ovarian cancer, hypocalcemic small cell type, immunotherapy has been shown to work. And there are some phase 1 or 2, so that's the sort of beginning of research programs of immunotherapy that are currently now closed, and we're waiting to see their results. So it's not that it's not been thought of in ovarian cancer, it's just that we're waiting for results. There are some fairly promising results. There were some results in ASCO, that's the American Society of Clinical Oncology, earlier on this year in June 23, that looked at a drug called PARP inhibitors. You all have heard of them. They've got the IBs after them. So that's olaparib, niraparib, the ones that you've heard about that are often used with ovarian cancer and women who have a BRCA mutation or alteration. I'm looking at putting the 2 in combination. Those early results are looking fairly promising for women with late stage, but we still need more information there. So that's why I haven't put a huge slide up, because we're still waiting. We're still really in research phase. Finally, before we go to the next slide, immunotherapy does work, though, in ovarian cancer and is used in ovarian cancer in a different way. Many of you will hear of the drug. It's called Avastin, also known as bevacizumab. That's also a type of immunotherapy. So it is used. but it is not dependent on whether a woman has a alteration in her BRCA genes or in Lynch. So immunotherapy is used, but it's used in a different way. So just for a bit of clarity there. Okay, enough of listening to me. I think our last slide is almost there. Oh, over to you, Lara. Get dotty.
All right. So, as you know, Tracie and I, we also do we are trying to raise awareness about Lynch syndrome. So we would like to thank Ovacome for giving us the opportunity to talk today, for being there today as well. We thank you for that. And I would like to encourage you on the 22nd of March to go dotty alongside Lynch syndrome UK. And hopefully Ovacome will go dotty as well to raise awareness about Lynch syndrome, because as I mentioned before, it's the most common cancer predisposition syndrome, and it's not rare anymore. It's underdiagnosed, and not many people go about it, and is that we only know about 5% of people. So it's really important that you help us to raise awareness. And this is some people that we work with alongside the National Lynch Syndrome Project, also some marks. We have quite a lot of fun going dotty, so it's not a really hard job. We would also like to direct you, if you have any more questions, please go to Ovacome. If you are finding it very difficult to cope, or you would like to meet more people that might have Lynch syndrome, and you would like to share your experiences, this is actually really helpful. Please contact Ovacome. There is a telephone number and a mobile phone number. There is also Lynch Syndrome UK charity, which is the UK charity for Lynch syndrome. So please get in touch with them. There is also Lynch Syndrome Ireland, if you are from Ireland. Really amazing people, and they have quite a lot of support groups, and they also provide quite a lot of really useful information, and sometimes very practical information that you also might need to hear about. Also, if you find it very difficult to cope with your diagnosis of Lynch syndrome, I put in this slide a link to one of the web pages from the RM Partners website. It belongs to the Lynch syndrome website, but it's got a list of apps or resources where you can obtain additional psychological support. But first point of contact, obviously, is Ovacome. And we would like to thank you for being here today. So back to you, Nina and Annie. I'm going to stop sharing.
No, thank you ever so much, Laura and Tracie. It was an extremely informative and comprehensive presentation, and I certainly learned a lot as well during that. So thank you. We really appreciate your time and sharing your expertise and all the interesting work that you're doing on this really important topic. And we've got about 15 minutes left for questions. Tracie and Laura have kindly agreed to answer questions this evening. So if you'd like to put any of those in the chat, we'll be really pleased to hear anything that you're unsure about, or anything you want to get Laura and Tracie's perspective on. And if we don't have time for everyone's questions, then Laura and Tracie have really kindly said they will follow up with a written response that we'll then circulate at a later date. So whilst people are having a little think, I know we had a few questions beforehand, a few questions from the team as well. So the first one is, someone said, I have a family history of cancer. Should I be tested for Lynch syndrome?
Laura.
Okay, so it depends very much on the family history, how many people is affected, and the age of onset of the cancer. So as I mentioned before, cancer is fairly common. 1 in 2 people in the general population, unfortunately, will develop cancer. This generally happens at not an early age. So if you have quite a lot of early onset cancers in your family, I recommend that you ask your GP to refer you to your clinical genetics department for an assessment. Now, if you have 3 family members that they are linked together and they have colorectal cancer, by all means, yes, or if anyone in your family develop colorectal cancer at the age of 40 or under, then yes. I think in ovarian cancer, almost everyone is eligible for genetic testing. Tracie, this is back to you.
You're absolutely right. So in England, if you are diagnosed with ovarian cancer, then you are eligible to be tested under what's called R207. So that's the number on the National Test Directory, and which your nurse or your oncologist or your surgeon is able to request if they've done the training to, which is called mainstreaming training, to counsel and consent to you and explain you what this test means. And that test covers not only BRCA1 and 2 and a couple of other genes within that panel, but also the genes that we've talked about with Lynch today. So absolutely. And that is when I say free, it means that those tests are centrally funded, so your hospital doesn't have to pay for the test. So every woman should have the eligibility, the decision. She doesn't have to be tested. That's your right, whether or not you want to be. But every woman should be offered testing now in England. Thanks, Laura.
Really helpful. Thank you both. We've had another question come in. Someone's asked, is sporadic mismatch repair deficiency inherited or just the bad luck of the draw?
Sporadic mismatch repair deficiency. Okay, so is that a question from someone in the chat that they have, obviously they have deficient mismatch repair, so deficient one of these proteins, but they have methylation present? Don't know if that.
I'm not sure. That's all the information provided.
That they put. Okay,
Yeah.
so it's not bad luck. Well, it is bad luck. It just happened by child, but it's definitely not inherited, because methylation is another process that is genetics. It causes cancer, but it's definitely not something that gets passed down through the family. Now, it generally happens the same as anyone that might develop cancer. It happens with age. So as you accumulate, you remember when I was going through the first presentation, when you accumulate these genetic alterations with sunlight, smoking, bad diet, etc., you will accumulate them, and then one person in two will develop cancer in their lifetime, but definitely not inherited. Is bad luck. Tracie, would you like to add anything to that?
No, I think you've got that covered, Laura. Thank you.
Thank you both. Someone's asked, what should someone do if they are due a screening, for example, a colonoscopy, and their local service doesn't have the capacity or they don't get an invitation? Oh, Tracie, you're just on mute.
Sorry. I would go to your, have you got me back now?
Yeah.
Cool. So how great that somebody is active about pursuing screening. And I think that's something that we do need to be, sort of gatekeepers of our own health. So good for that person. I think your GP is always a good point of call as to having a healthcare provider to help you through that myriad of what is an enormous maze sometimes of getting the screening process right. Laura was explaining there has been a changeover or a reshift with how the national screening program and is working, and quite often there is a shift in how databases are moved around, administrative glitches, and it could be something really simple like that. So enlist the help of your GP to help you through that maze. Laura, would you add anything else to that?
No. I think you answered it correctly. Just to remember that it's a little bit of backlog still from COVID. So, if there is a delay of 1 or 2 months, probably the service is just a little bit of backlog. If it's longer than that, please do get in touch with your GP ASAP.
Thank you very much. We've had another question come in. Someone has asked, Please can you talk about how you get diagnosed with Lynch syndrome? I've had ovarian cancer and a family member who had bowel cancer, both young onset. I was told that my tumour needed to be analysed first and it couldn't be found.
Okay. So what this person is talking about, and I'm really sorry to hear about your cancer and your family member who had bowel cancer young. It really does feel like, could this be bad luck, or could this be this inherited risk predisposition? Especially because, as you're saying, this is two cancers at a young age of life. What they're talking about, and that is what your team will have thought, what they're talking about is when they do the tumour test, what they mean is they test the tumour to see if they can see any of these mismatch repair genes, or sort of like a precursor, a change to suggest in the tumour that there might be something in these genes, to see whether or not you have Lynch syndrome. Now, in ovarian cancer, it's slightly different to bowel cancer. In ovarian cancer, we don't look at the tumour. We do a germline blood test. It's called R207 that I was talking about. That will cover the Lynch genes. So I'm not quite sure what they mean for the ovarian cancer situation here, because actually, although we do test the tumour in ovarian cancer as well, we do also test the blood. So if it would be useful, I'm more than happy to take this, as it were, offline and to go through Ovacome. So to share your question with Ovacome, and we can look at that a little bit more closely from the ovarian side of the diagnosis. The bowel cancer, now that would be different. That is where we do look at the tumour. So I'm going to get Laura to explain that.
Well, if the other person in your family have colorectal cancer at the age 40 or under, they should have access to genetic testing straight away. So it doesn't really matter if you get tested or your family member that is closely related to you on a first degree basis. What I mean by first degree relatives is parents, siblings, and children. So if they are closely related, they should get access to that. And if they get diagnosed with Lynch syndrome, they just should be able to have testing. A little bit the other way around, but I think Tracie, from what Tracie had said, you got access to genetic testing, so you might as well get that yourself. But definitely, I will leave it with Tracie. I will follow that up. And for anybody else that might be in the same situation, I will ask them to go to their GP and get referred to clinical genetics.
Thank you very much indeed. Thank you. The next question, someone has said, I was diagnosed with stage 4 ovarian cancer in May 2020. I have 3 cousins who have had gynae cancers. I was tested for BRCA and negative, but do I now qualify for a Lynch syndrome test? I'm keen to find out, as my daughter has just had several benign colon polyps removed.
Tracie, this is for you.
Okay, so in your family, there are 3 gynae cancers. So the thing is with gynae cancers is there are 5 different types of gynae cancers. So it gets a bit complicated, doesn't it? It's being negative for BRCA. If you've had the R207 test, you will have also simultaneously been tested for Lynch, because what we call it's called a panel of genes. So there are about 6 or 7 genes on the R207 test that is done, and that covers BRCA1, BRCA2, BRIP1, BRIP2, and it also covers the Lynch gene. So you've simultaneously been tested for Lynch by proxy. So now we're talking about the different types of gynae cancers. If the other gynae cancers in your family have been, for example, cervix or vulva, then actually we don't have that link there with Lynch. If it's been endometrial womb, it means the same thing, and it's been at a younger age, then there's a potential link there. So it's a little bit more complex, and I hope the conversation, or rather the explanation I'm giving, is not trying to make it sound more complicated. Once again, this is another one that I'm really happy to take offline via Ovacome if that's useful to help. And you know, Annie and Nina can come to me and we can do this anonymously for you. My main thing is if those 3 other gynae cancers are not ovarian or not womb, then we're not looking at what with somebody it's sort of like what we call like a Lynch-like picture. It sounds like this is just damn bad luck again, and I am so sorry, but we can go into this in more depth for you.
Thank you very much indeed. Absolutely, we can follow up with the individuals who've sent those questions and try and go into them a bit further. So I think this is the last question that's come in at the moment, but do drop in any others if people still have them. Someone has asked, is Lynch syndrome applicable to all types of ovarian cancer or just some? I asked because I was diagnosed with mucinous ovarian cancer and have asked to be tested for Lynch. I'm still waiting on option, but the testing people said that mucinous cancer was more likely to be linked with Lynch than others. I should have added that I asked for the test because we also have a history of bowel, kidney, breast, and pancreatic cancer in our family.
Okay, should I take this one, Laura? Yeah? Okay, so the most common of the gynae cancers is serous papillary. We're not talking about that here, we're talking about mucinous, which is why people tend to, why clinicians, when we're talking about genetics side of things, think, well, actually, if it's the more unusual of Lynch, mucinous, then it's more likely to be Lynch. There's not a phenomenal amount of information about that, but what is good is that your clinicians are thinking out of the box. The real reason that they're thinking out of the box, you've got a good team looking after you, is because they're looking at the other cancers in your family. So they're looking at bowel cancer. We see that in Lynch. They're looking at breast cancer. We don't really see that in Lynch, I have to say. Kidney and pancreatic, yes. However, it gets more complicated again. I keep saying this, don't I? But we also see when women have an alteration in BRCA, we also see pancreas and breast in the family. So you can see this genetic hunting, if you like, being a DNA detective on your behalf, your team. It really isn't that easy. So I would have thought that actually they might be looking at doing a full panel for you. When you're having a genetic test, when you're talking to your team who are clearly on the right lines, thinking about, well, how should we, your name's Jodie, I hope I've got that right, Jo. How do we look after Jodie? How do we manage your genetic testing? I would have thought they will be looking at actually a full panel for you, like the R207 panel. So you've got your BRCA genes and you've got your Lynch genes covered in one go. It doesn't cost the testing laboratory any more money, Jodie. In fact, it's just easier to do that R207 panel. So that's what I think they should be looking at for you. And I imagine they probably are, but rightly so, because it's mucinous. They're thinking, because mucinous tends to be more, we tend to see it arises in the appendix, which is why we think colon, and that's where we think colon, and we think Lynch. So you can see they're following through. That's great, Jodie. I'm glad they're doing that. Best of luck with all of that.
Brilliant. Thank you very much indeed for all of those really helpful answers. And we've come to the end of our time already, which seems to have flown by. So thank you very much indeed to Laura and to Tracie again for this really useful talk, and to everyone who's logged in at home. It's great to have everybody join us. And as we've mentioned before, please do get in touch with us at Ovacome if you've got any questions, or if anything comes to mind after this webinar. We'll be very pleased to hear from you and help if we can, or pass on any queries to Laura and Tracie. But we will follow up as well with those other queries in a bit more depth from today. So thank you all so much indeed, and we look forward to welcoming you to another Ovacome event soon.